Hello, my name is Kimberly Weitzman. I am a QA and training manager at ViaQuest Psychiatric and Behavioral Solutions. This is a training about understanding and responding to behaviors related to mental health diagnosis. You'll see my email address there at the bottom of the screen, kimberly.weitzman@viaquestinc.com. Please feel free to contact me with any questions that you may have regarding this training, or please always consult your supervisor, especially with questions that may pertain to policies and procedures. So we'll be talking kind of generally today about mental health and some behaviors that you may be supporting clients around as part of your job. So our objectives for today's training are to, first of all, learn how behavior really is, essentially communication. Hopefully you will understand several ways to look beyond the behavior or to look sort of underneath the behavior to identify any unmet needs in your residents. We will talk about the connection between trauma and what we call survival behaviors. We will go through a list of internal and external triggers for behaviors that are related to symptoms of your resident's mental health diagnosis. And the last topic is about differentiating between empathy and sympathy as we, as staff, choose how to respond to our residents' behaviors. So that is what is in store for today's training. But let's start first with some definitions. What exactly do we mean when we are talking about behaviors, specifically in this training that you're in today? What we're talking about are actions on the part of the resident, which may be harmful to them or to those around them, actions that could interfere with their life or the lives of those around them, and also actions that might be disruptive to social interactions. That's what we mean when we say behaviors for the purposes of today's training. So I want to start first with talking about behavior in terms of it really being communication. Thinking about that behavior really serves a function, that there is usually a reason why people are behaving in the way that they do. Behavior is often learned by imitating others, and it is utilizing trial and error. If a particular behavior gets somebody what they want or what they need, they are much more likely than to repeat that behavior, almost reinforcing it for themselves that that behavior, quote unquote, works for them. Another function of behavior is that it can be used to communicate an unmet need. It might not be overtly evident that a behavior is communicating an unmet need, but that might be what is underlying the behavior. And we'll talk about needs here in a second, but first, let's talk about how behavior really is part of a sequence, because rarely does behavior occur, quote, out of nowhere. There is an antecedent, or another word to use that is, another word to use for antecedent is trigger. And that is the situation that happened prior to the behavior of concern. Sometimes that antecedent, or sometimes that trigger, or sometimes that situation is known to us as a staff, and other times it happens out of our view, or it happened either months or weeks or even years earlier. So we may or may not always have that knowledge of what even the trigger or the antecedent was. But usually there is something that triggers that behavior. We then see that behavior of concern. And then as a result of that behavior is what we call the consequence. What happened after that behavior was displayed or demonstrated? What was the outcome of that situation? What was the outcome of that resident displaying that behavior? So just, a reminder that rarely does behavior occur out of nowhere. Rarely is behavior displayed merely to upset or to irritate or to manipulate staff. Usually it is in response to some sort of trigger that we may or may not be aware of. Another thing to consider is that behavior can communicate an unmet need. And just very quickly, I will give a brief overview, introduction into Maslow's hierarchy of needs, in case you have not heard of Maslow and his hierarchy of needs. Just again, very quickly, Abraham Maslow was a Jewish American psychologist and researcher in the early part of the 19th century who came up with a theory that every human being has particular needs. But not only do we have particular needs, but often these needs need to be met in a particular order. And first comes our basic human needs, things like our physiological needs. So having food, having clean water to drink, having fresh air to breathe, having shelter, being kept warm when it's cold, being able to cool down when it is hot, the ability to sleep and to be rested. Some other physiological needs, depending on who we're talking about, might be medication. So there are many physiological needs. Sometimes certain versions of Maslow's hierarchy of needs also put sex in that category. There's several different versions of Maslow's hierarchy of needs. This is the original one. But once people's, basic needs are met, once they're fed, once they have clean water to drink, once they have appropriate amount of sleep, the next need that people tend to look to satisfy are what we call their safety needs. So feeling of security, whether that's where they live or where they work or where they go to school, wherever they find themselves, a need to feel safe, a need to feel secure. The ability to predict what is going to happen in their environment also falls under safety needs. So that routine and that predictability also comes into play when we look at safety and security. So after a human being's physical needs are met, once somebody is feeling fairly safe in their environment, the next need that seems to pop up is the need for belongingness and love. So to have relationships with friends and with family comes next once safety and physical needs have been met. It is a basic human need to have relationships, to be touched is a human need. We know that if babies aren't held and if babies don't experience touch early in their lives, they don't grow, they don't thrive. And if it becomes severe enough, they sometimes even die if they don't have that physical contact and relationships with the caregivers. The next order on Maslow's hierarchy of needs, after physical needs, after safety needs, after relationship needs, are esteem needs. So now talking about our own personal sense of accomplishment, our own sense of achievement. Having goals and being able to meet them are some ways to think about esteem needs. And it really makes sense that that would come after our physical needs have been met, our safety needs have been met, and our relationship needs have been met, because it's hard to focus on accomplishing a goal or even setting a goal if you're hungry, if you're dehydrated, if you're tired, if you don't feel safe and you're constantly on alert for dangers. And it's also hard to work on our goals and to achieve our goals if we don't have people in our lives that are supportive of our goals. So completely makes sense to me that a sense of achievement and accomplishment and having self-esteem comes after those first three needs that we see at the bottom of the hierarchy. At the very top of Maslow's hierarchy of needs is what is called self-actualization, which is kind of a fancy word for meeting one's full potential, including being creative. We're finally free to have fun. We're finally free to enjoy ourselves and to enjoy our lives and to enjoy the world around us once we, again, have met our physical needs. We feel safe. We have positive, supportive relationships. We're feeling good about ourselves, and we can finally now relax and have fun. So that is one way to think of self-actualization. I just want to point out that one person's idea of self-actualization might be very different from another person's idea of self-actualization. For one person, being quote unquote self-actualized might be to graduate from high school. Somebody else's idea of self-actualization might be to become a parent, or to get a particular job. So it's going to be different from person to person once we get up to the top of self-actualization, but our physiological needs are pretty similar from person to person. We all need food, we all need water, we all need shelter, we all need sleep and medication. I also want to point out about self-actualization that we don't always just stay in self-actualization. Depending on our circumstances, we may feel self-actualized on one particular moment, but maybe something happens in our life, one of our other needs are threatened, and we are no longer feeling self-actualized, and we have to work back up to it. So as that relates to our clients, we want to think about their behavior communicating an unmet need. And whenever I explain and teach about Maslow's hierarchy of needs, I'm always reminded of a particular client that I worked with when I was a case manager. This was a young lady who was mostly nonverbal. She communicated with sounds and with gestures. And so she couldn't always use words to communicate an unmet need. So I remember as a case manager getting some phone calls from her residential staff saying, all of a sudden, this young lady is becoming aggressive with staff, and she's also starting to engage in some self-injurious behavior, which she had never displayed either of those behaviors before. So knowing her history and knowing her personality, I said, let's get her to the doctor as soon as possible, because this is just not like her. Once we got her to the doctor, we found out that she had a UTI. She had a bladder infection. And if you've never had a UTI, they are very painful. So no wonder she was becoming aggressive with her staff. No wonder she was scratching at herself. She was trying to tell us, I'm in pain. I need help, get me to the doctor. But she didn't have the words to tell us that. So as we're thinking about needs, and as we're thinking about communication being a result or being an outcome of behavior, those needs can be actual, like this young lady with her pain of her UTI. She actually was in pain and was communicating that with her behavior. But sometimes a need can simply be perceived. One person can open up their cupboard and see several cans of food in there and feel as though, okay, I have enough food for the next couple days. I feel as though that need has been met. Other people may open up the cupboard, and if there's only several cans of food in there, may feel insecure that, oh my gosh, I don't have enough food. I need to have a completely full cupboard and refrigerator full of food in order to feel as though my need has been met. So just like it says there on the screen, a person's needs can be actual or perceived, in spite of us not understanding or maybe not agreeing with that person. If that is an actual or a perceived need, it is still very real to that person. So it's not how we feel about that person's need, it's how they feel and perceive the situation around their need. So please, we're going to be talking today about taking the perspective of our resident, or taking the perspective of the other person, and that will help us to understand them and help us to understand how we can support them to get those needs met, especially if it's leading to a problem behavior. Something else that can influence behavior is past trauma or current triggers that are reminding somebody of trauma. So behavior may be a response to trauma or a reminder or a trigger of a previous trauma. And according to the Center for Disease Control, who has conducted a very extensive study about trauma, specifically what are called adverse childhood experiences, or ACEs. Those are potentially traumatic events that occur during childhood between the ages of from birth to age 17, and are experienced such as violence, abuse, or neglect, witnessing violence in their home or in their community, having a family member attempt or die by suicide, or growing up in a household where there are substance use or abuse problems, mental health problems, or parental separations or household members being in jail or prison or otherwise away from the family. Those are some examples of ACEs or adverse childhood experiences that were studied in the CDC research. Um, those ACEs, or those adverse childhood experiences, then are linked to the following in adulthood: things like chronic health problems, mental illness, substance use problems. Having those adverse childhood experiences then as an adult can negatively impact one's education, one's job opportunities, as well as one's earning potential. So we don't want to forget about what may have happened to our residents growing up, because ACEs, or adverse childhood experiences and trauma, are much more prevalent than you might think. According to the Center for Disease Control, about 61% of adults that they surveyed across 25 different states reported that they had experienced at least one of those ACEs that I just mentioned, and nearly 1 in 6 reported they had experienced 4 or more of those adverse childhood experiences. So that is a quite significant chunk of the population here in the United States that have experienced at least one or more of those adverse childhood experiences. So because trauma is so prevalent, this is why it is so important as staff to become trauma informed. And if you have not heard that term, trauma informed, before, to be trauma informed means that staff assume that an individual is more likely than not to have some sort of trauma history in their background. Providing trauma informed care recognizes that the presence of trauma symptoms and acknowledges the role that trauma may be playing in that individual's life. So we just kind of assume that this person may have experienced some sort of trauma, even if we don't know exactly what that trauma was. It is highly likely that they experienced it at some point in their life. Excuse me. Becoming trauma informed also means that as a staff person supporting other human beings, you recognize the potential for re-traumatization, and that it exists in all systems and in all levels of care, from individuals to staff, as well as the system or the organization or the agency that we're working for. It is possible to re-traumatize our residents or our clients. We want to remember, though, that re-traumatization is often unintentional. There are some obvious practices that could be re-traumatizing, such as using restraints or isolation, but there are also some less obvious practices or situations that could involve specific smells or sounds or types of interactions that could cause an individual to feel re-traumatized. For instance, if a person was institutionalized for a period of time in their life or was hospitalized for a time in their life, simply the smell of bleach or the smell of cleaning chemicals that are common in hospitals or in residential facilities could immediately trigger or remind them of a traumatizing experience they had in that hospitalization. So even sounds or smells, or being called a patient, or being called a consumer, or being called a client could be re-traumatizing to a person. So we want to be very sensitive in all of our interactions to not re-traumatize the folks that we're supporting. What you see on the screen here are 4 typical trauma responses that we see frequently in people who have a trauma history. The first one is what is called flight. It could be as simple as running away literally from a confrontation or avoiding people who are triggering, but it could also present in other ways that we fly away from our problems by focusing on other things such as work. People may also be considered to be in flight mode if they are overthinking, if they're experiencing a lot of anxiety and panic, if they're having OCD symptoms, even if they have difficulty sitting still or if they have perfectionistic tendencies. All of those could be an example of a flight response to trauma. Other people engage in fight responses to trauma. It could be actually fighting in response to a trigger or in response to a confrontation. It could also look like anger outbursts, trying to control others or to control the environment around them. They may be seen as the bully in interactions. They may display narcissistic symptoms or tendencies. They can also have explosive behavior. So depending on the person, depending on their history and what it actually is that they have been traumatized by in their past, or what it is that they're afraid of, they may either fight or flight. And people can do both. In some situations, they may be a fighter, and in other situations, they may be a fleer. Other folks are more of freezers, where if they are confronted with something that frightens them, or if they are confronted with the trauma, they literally freeze up, don't respond, or don't know how to respond. It could also look like difficulty making decisions, physically being stuck, or mentally or emotionally being stuck in response to that fear or that trigger. They could also disassociate from the situation as a way to survive or cope in that fearful situation. They may isolate, and they may also report feelings of numbness, emotional or mental numbness. Not uncommon for people to freeze as well when they are in a confrontation. One that you may not have heard about as much is the fawn response. This looks like a person who is a people pleaser, who may not have their own identity, may find their sense of identity in others. They may have no boundaries or very few boundaries. We may see them being easily overwhelmed as well as codependent. And this is also a survival skill or a coping skill that a person develops in response to fear or in response to trauma. So I encourage you to look at your residents as far as a flight, a fight, a freeze, or a fawn response, and just think about how that could be somehow related to them being afraid, or them having a trauma history, or being triggered in a particular situation as it pertains to their trauma. Unfortunately, I don't have time to show you this very inspiring and amazing and informative and educational documentary called Healing Mean, which is based on Tonier Kane's book that she has written of the same name. Just very quickly, Tonier Kane is both a trauma survivor as well as a trauma educator. She is a trauma-informed care expert. So I encourage you to check out her website, to just Google her and watch that documentary, or even read her book. At the end of this PowerPoint presentation, I have listed her website in case you're interested in her very inspirational and educational story that she has. I wish I had time to do it now, but I do encourage you to do that if you have the time for it. Okay, so now that we're starting to really understand our clients and their behavior as it relates to them communicating, as it relates to unmet needs, as it could be relating to trauma, we want to think about looking beyond the behavior to identify what those unmet needs could be that they are trying to communicate to us. So it really is our job as staff to figure out what is fueling that behavior. So start thinking about asking yourself some questions such as, what has happened to this resident? What is their trauma history? Has there been a time when their needs were not met? What does this resident need right now? What is this resident trying to communicate with their behavior? Think about, is this an attempt on the part of the resident to deal with internal factors that are going on inside of them, or perhaps to gain control over their environment? Think about how small your residents' worlds are becoming as they are living in a long-term care facility. They may not have control over what they eat. They may not have control over when they take their medication, when they get up, when they go to bed, when they take a shower. The list could go on and on and on. And especially now with COVID-19, they don't have control over seeing their friends or their family like they used to. So maybe their behavior is one way they can exert control over their environment. What we want to avoid is asking questions like, what is wrong with this resident? Or to take it personally by asking questions like, what is this resident doing to behave this way towards me? Why are they lashing out at me? Why are they calling me these names? Let's do our best. I know it's hard, but to not take behaviors personally, remembering that it is probably relating back to something that's going on with them and may not be anything to do with us. So some other questions to ask as a staff as we're trying to figure out what is fueling the behavior is to think about, why is this behavior challenging? How severe is this problem behavior? Is it just distracting? Is it slightly disruptive? Or is it destructive to property? Or is it dangerous to the client? Or is it dangerous to those around you? If it is destructive or dangerous, we do want to intervene as we are guided by policy and procedure for the facility that you work with. But if it is just simply distracting or annoying or slightly disruptive, let's think about picking our battles and only intervene if it is a threat to health or safety. Another thing to remember is that behavior really is value neutral. It is the consequences of the behavior that are either positive or negative, and even that is subjective. So we want to be careful not to put our values on a particular behavior by labeling a resident as manipulative, because all human beings actually use manipulative behavior to get what we want. It isn't just residents. And the example I always use when I get to the topic of manipulative behavior is before COVID times, when we could go to restaurants on a regular basis. I myself noticed that I displayed some manipulative behavior as a customer in a restaurant. Multiple times I caught myself at the end of the meal, straightening up the table, stacking up the dishes, stacking up the cups, to signal to the waiter or to the waitress that, hello, I'm done eating. I have cleaned up my environment. I would like my check. I would like to pay, and I would like to get out of here. That really is a manipulative behavior. I'm using my environment to get what I want, to signal to the waiter or the waitress. So we all use manipulative behavior. It is not just the residents that we work with. It isn't positive or negative, but it is the consequences that are positive or negative. Usually 9 times out of 10, by neatening up my restaurant table, I was able to get my check, and it worked for me. So I have done that since, and that is the same for our clients. If a manipulative behavior is working for them, they're much more likely to continue using that manipulative behavior to get what they want or to get what they need. So just some more recommendations for you as staff as you are trying to figure out and get to the root of the behavior is to really pay attention to the behavior. When does it occur? Does it tend to occur in the morning? Does it tend to occur at lunchtime? Does it only occur with certain staff? Does it only occur in certain areas of the facility? Does it only occur around other residents? Try to pick up on those clues and those patterns to get to the root of the behavior. Learn to think about the behavior's purpose and not just simply react to it. Again, all those questions that we just talked about. What are they trying to communicate? What do they need? And not just saying things like, we can't do that, or, we don't act that way, or stop what you're doing. Don't just react. Play investigator for a second, which requires us to slow down and pay attention to not only what is happening to the client and to others in our surroundings, but to think about what's happening within you as the professional. How am I reacting? How am I presenting myself? Am I somehow reinforcing this behavior, or am I somehow causing this behavior. It more than likely is unintentional, but there could be a role perhaps that you are playing in fueling the client's behavior or the resident's behavior that we're looking at. It also could be an internal trigger that is going on with the client that relates directly to their mental health diagnosis. So let's talk about some things to consider that could be going on internally with the client. Please consider their diagnosis. Do they have dementia? Do they have Alzheimer's? Do they have a mental health diagnosis that could be the reason for the behavior that we're seeing? So let's start there. Are they experiencing hallucinations and delusions? And is their behavior rooted in those? Think about the medications that they're taking. Are they experiencing side effects that make them agitated or that make it difficult for them to sit still? That could perhaps explain the behavior that we're seeing in a client. Think also about what's going on in the client's life. Is there an upcoming anniversary of the death of a parent or a sibling or a child or somebody close to them? Is that what is causing them to be extra sensitive? Is that what is causing them to display the behaviors that we're talking about? Not everybody enjoys the holidays. So is there an upcoming holiday that might be difficult for that client to experience and to get through, especially if they don't have their friends and their family able to be around them during that difficult time of the year or that difficult holiday. Another thing to consider is the time of year. Sometimes folks have seasonal depression. Think about also that being a factor as far as behavior. Is it the time of year? Very well could be. Some other mental health symptoms that are related to triggers for behaviors are things like being very sensitive as far as a person's senses are considered. People, whether they have a mental health diagnosis or not, can be very sensitive to heat, to cold, to lightness, to dark, to particular sounds, to particular smells, to being in a very chaotic environment. So their surrounding, level of activity, if it's chaotic, could be a trigger. If they suddenly don't have the privacy in this facility that they're used to enjoying in their own home, that could be triggering behavior. If they're in an unfamiliar environment, let's consider that as a trigger for behavior. Think about the cleanliness of their environment or the orderliness of their environment. It might not be up to their personal standards. They could be wearing uncomfortable clothing, again, a sensory issue, or they could suddenly be wearing uncomfortable medical devices. Maybe it's dentures that they're not used to, or some other kind of medical device, hearing aids that they're adjusting to. We all are sensitive when it comes to our senses, and some people are more sensitive than others. We also want to keep in mind isolation, that even more so than normal because of COVID-19, that could be exacerbating people's mental health symptoms. Does this person need some extra attention? Do they need some problem solving as far as getting on the phone with friends or family, or using Zoom or using Skype? How can we help with isolation? And if it's a newer resident, remember that they may be having an adjustment period to suddenly living in a new facility, to suddenly being around new people, and to suddenly, be having new surroundings. Maybe they've never had a roommate before. Maybe they're not used to the layout of the facility yet. All of these things could perhaps be contributing factors when it comes to behaviors. And a lot of them are related to mental health symptoms or perhaps medications. So for all these reasons, we really want to have empathy for our residents. We want to avoid having sympathy. So we'll first have some definitions here of empathy versus sympathy. Empathy is one's ability to understand and share the feelings of another. Really, it is feeling with somebody. Versus sympathy, on the other hand, which are feelings of pity and sorrow for someone else's misfortune. It's feeling bad for somebody. it feels very different to be on the receiving end of empathy than it does to be on the receiving end of sympathy. It feels very different. A couple months ago, I was teaching a class and I had a student tell me that her father recently passed away. And at the funeral for her father, people were coming up to her and saying things like, well, at least you still have your mother, which is factually true, but completely ignores the fact that she just lost her father. It feels as though we are ignoring a person's feelings when we express sympathy. On the other hand, empathy is really trying to understand where the person is coming from, to understand their experience, and to try to find within ourselves something similar that we may have experienced, or trying to imagine what it must be like to be that person. So, as much as possible, we can feel with them. So, we're never going to 100% feel exactly like they feel, but we can certainly try to feel as much as possible in a similar way to what that person is feeling based on what they are experiencing. And the best video I have found that I think illustrates the difference between empathy and sympathy is from a TED Talk by Brene Brown. If you have never heard of Brene Brown, she is kind of the foremost expert on empathy and compassion. And so we will actually take a few minutes to watch a quick video that really does illustrate well empathy versus sympathy. So I will go ahead and play this, and then I will see you on the other side of the video.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no. You want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now. I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Okay, so I love that video. I think it really illustrates the difference between empathy versus sympathy. But I want to just make a couple comments about sympathy that I completely understand how it's somehow hard to know what to say a lot of times. And so we feel like we have to say something. And oftentimes what comes out of our mouth is a sympathy statement. But I also want to say, that we here in, the social services fields, we in the helping profession are in this field because we want to help people. We want them to feel better. We want them to have better lives. But sometimes there is nothing we can do. There is nothing we can say that can make their situation better. And so it's kind of counterintuitive to get away from sympathy and go towards empathy. But if you think about, the fact that sometimes people just need to be listened to, sometimes they just need to be heard. And that really is exactly what empathy is, that it requires us to listen and to understand, especially if there really is nothing else that we can do. So this is not easy to do. I still struggle with responding with empathy versus responding with sympathy, but it takes practice. It takes understanding what the difference is, and it takes really thinking about what you're going to say before you say it. So practice, practice, practice empathy. It is possible, and it does get easier, but don't put too much pressure on yourself if you find yourself slipping into sympathy, because this is a difficult thing. This is a difficult skill to develop. So just being mindful to try as much as possible to go the route of empathy and try to avoid sympathy as much as possible. Okay, so you're probably wondering, how do I actually respond to behaviors? We've talked a lot so far about just understanding behaviors, thinking of where they may be coming from, thinking about trauma and needs, and thinking as behavior as being communication. So I haven't really given you very many tips or tricks on what we should actually do. And I will be honest with you, I don't have an exact prescription for how to respond to those behaviors that we're talking about in this particular training, because every situation is different, every resident is different, every day is different with a particular resident. So I have some general things to consider as we are responding to these behaviors. And I hope that you see that running throughout all these suggestions are reminders that staff behavior is communication too. So again, I'm not blaming staff for seeing these problem behaviors in your residents, but I do encourage you to take a good look at yourself, do some self-reflection, and think about what in my behavior or what in my communication could maybe prevent some of these behaviors. It comes back to the relationship that you have with your residents quite a bit of the time. So how do I respond to behaviors? We've already gone over understanding the behavior and its purpose. Try to get to the root of what is the purpose of this behavior. Is it an unmet need? Is this person not feeling safe? Is this person having a trauma response? Or is it related to their mental health diagnosis? Are they experiencing hallucinations or delusions or side effects from their medications? Do what we can to be proactive. If we have really studied the behavior and we have found that maybe bedtime is a particularly difficult for our residents, how could we plan ahead so that that behavior is less likely to occur? What could we do to make bedtime less stressful, less triggering, and a more enjoyable experience if that is what we have noticed about a particular resident and their behavior? So we can't prevent every crisis, we can't prevent every behavior, but there are quite a few things we can do to be prepared or to prevent behaviors from occurring. Obviously, we will need to intervene as necessary to keep our residents safe, but please follow your company policy. I know I myself have worked at many agencies where we do restraints, and that is our policy, to keep clients safe from themselves and to keep other people safe. Please, follow your policy in regards to safety and intervene only when necessary to keep people safe. And even in every interaction, even when a client is displaying difficult behavior, we want to be demonstrating respect. And I would say that residents deserve even more respect and compassion if they are having a difficult time and displaying a behavior. So just, showing that basic human kindness and treating folks with dignity and respect can go a long way to de-escalating folks who might be headed towards a crisis. Number 5 is to teach acceptable ways to get needs met, as well as giving options. Maybe we just need to inform one of our residents on how they can get that need met. How can they request something that they would like to eat for dinner? How can they get in contact with their family members? So teach them the ways in which they can get those needs met. That will help them to have a sense of control over themselves and over their lives and over their situation, as well as giving options. People like to have choices. This helps them to feel in control as well. So even if it is something as simple as, would you like to use a blue towel, a yellow towel, or a green towel? Sometimes even just having that kind of a choice helps people to feel in control and can help, de-escalate somebody who might be headed towards crisis. Number 6 is to consider your own behavior and what it is communicating. So think about things like the tone of your voice, your posture, your body language, your level of eye contact, the words that you're choosing to use. All of those could be triggering to a client. As far as the tone of our voice, sometimes people don't think they have control over the tone of your voice, but with practice, you really do. And just keep in mind that the lower you speak and the slower you speak, the more calming we sound, the more of a calming effect we have on those around us. So listen to yourself. Do what you can to not speak really fast and to not speak really high and to not speak in this kind of a level of sound, because this causes anxiety. Think about taking a yoga class. If you were to take a yoga class from a teacher who was talking really fast and talking really loud and talking really high, that would not be relaxing. But if you are taking a yoga class and the teacher, is talking very softly, is talking very slowly, is talking in a lower register, you automatically are going to feel more relaxed as well. Also think about your body language, your posture. What is that communicating? Are you standing in such a way that shows that you are scared of the client or that you are ready, to fight or respond to the client? Think about giving personal space to the client, to give them that space to cool off, to cool down. Think about the words that you're using. We want to avoid using nicknames or other names that could be triggering to a client. Use their actual name. Sometimes using terms like sweetie or darling or dude could be triggering and could only escalate the situation further. Some other ways to think about responding to behaviors are to get support from your coworkers and from your supervisors. Maybe they have some tips and tricks for dealing with clients that they may have a better relationship with than you do. Or maybe they just have more experience dealing with that client or that resident. They can give you some ideas of the best way or the best time to approach that particular resident to help them to de-escalate. Please also remember that behavior is satisfying a human need and it works for that person. If it didn't work, they will try a different behavior, which is exactly what number 9 says. New behaviors must work better to bring about change. If I could figure out a different behavior to display to get the waiter or the waitress to bring my check over to me, I will stop straightening up the restaurant table and I will do whatever that new behavior is. But it's been working for me so far, so I have continued to do it from time to time. Another great tip is that it is often easier to focus on what to do instead of what not to do. So we want to avoid making statements like, stop picking at your skin or, stop yelling, because if we tell somebody what not to do, they are often left wondering, what do I do? And they're at a loss. But if we could say things like, let's take a walk. What if we put together a puzzle? Let's get out of this room and go somewhere else. Give them some options on what they can do. That will help them, again, feel a sense of control and feel as though they have choices in their situation. Number 11, please always look at the big picture as well as the person that we are serving. Let's not focus on this particular behavior, but also focus on what happened before it. What is their trauma history? What are their unmet needs? Let's not focus on what is happening in this moment, but let's try to look at the whole big picture. And really, our focus is to keep people safe and healthy. What could we do in this moment to improve the moment? What could we do right now to keep this person healthy and safe? What have we learned about them in the past that might help us keep them healthy and safe? Don't be afraid to draw upon past successes. Many times I have said to clients things like, we have gotten through difficult situations before, and we're going to get through this difficult situation as well. So, reinforce past successes, draw upon them, and remind the client of the relationship that you have with them and that you are there with them to help them. Which is kind of related to number 12. Reflect on your relationship with the resident. When people trust us, they feel safe. And when they feel safe, they often feel in control. Again, likely to help de escalate, likely to help those problem behaviors to dissipate. To build trust, what that comes from is saying what we mean to that resident, meaning what we say, and then following through, not making empty promises, only, being truthful and honest with that resident. That is what helps to build trust, but that comes over time. We are not going to build trust with a client on the first day that we meet them. It will happen interaction after interaction after interaction. So I believe, yes, that brings us to the end of this training. Here is a list of the references that I used to put together this particular training. I am providing Andrew with a copy of this PowerPoint, so you'll have a list of those references in case you want to check out Tony or Kane, or in case you want to watch that Brene Brown video about empathy versus sympathy again. Or, I also recommend looking into Maslow's hierarchy of needs. That applies in many situations and in many cases with our clients. So I hope that this helps you to gain a better understanding of behaviors. I hope that you might see your clients in a slightly different way. And I hope that you make, some different choices when responding to clients when they are displaying some difficult behaviors. I hope that you think about responding with empathy. I hope you think about giving choices. And I hope that you remember that there may be a trauma or an unmet need that is really fueling that problem behavior that you're dealing with in the current moment. So I appreciate your attention, and I wish you best of luck as you support your residents. Thank you so much.